Thanks for being here, gentlemen, today. And your presence speaks volumes of the importance of this topic, very near and dear to my heart, having been the benefit of Army medicine for 30 years as a soldier, but also seeing the benefit of them saving countless lives on the battlefield, to include that of my spouse, Army medicine. So thank you. Welcome to AUSA's Hot Topics, the first panel of today. They always put the best team up front, so this and that tradition holds true today. So I'm retired Sergeant Major of the Army, and I have the honor of serving as the moderator for our panel today, titled Army Medicine in Multi-Domain Operations. You know, the United States Army is the most lethal and capable ground combat force in history. It has proven this in multiple conflicts across a broad spectrum of operations in various locations around the world. Army medicine conserves the fighting strength of the Army by optimizing soldier performance, as well as treating the wounded, the ill, and the injured. Throughout the Army's campaigns, from the biting cold of Valley Forge to the scorching heat of Iraq, Army medicine's history demonstrates an ethos of selfless service and innovation in expeditionary healthcare. Army medicine must embody these ethos to remain first among peers in expeditionary medicine. Our adversaries' goals, the pace of technology, and advancements of the changing character of war will inherently create challenges and opportunities for the Army to maintain battlefield superiority. Army medicine must take advantage of the complex and volatile environment, and Army medicine's role in supporting the Army in future multi-domain operations is vital to our success. Here to speak to us today about the future of Army medicine in multi-domain operations is two gentlemen that have spent decades in this business. First is Major General Joe D. Robinson. Native of Lubbock, Texas, he graduated cum laude from Monterey High School in Lubbock in 1978 and continued his education at Texas Tech University, graduating cum laude with a Bachelor of Science in Zoology in 1982. From 1983 to 87, Major General Robinson attended medical school at the University of Texas Health Science Center, San Antonio, Texas, and he completed his residency at the University of Texas Health Science Center in anesthesiology in 1991. Major General Robinson is board certified by the American Board of Anesthesiology and maintains his medical license in Texas and the state of California. Prior to assuming the position of Commanding General of 3rd Medical Command Deployment Support, he previously served as the Deputy Commanding General for the same organization. Ladies and gentlemen, please welcome Major General Joe D. Robinson.
Thank you very much. So, Major, it's an honor to meet you. People ask me why I got a degree in zoology. It's real simple. I walked in my senior year, and the professor said, we know all of you are pre-med majors. I don't care how many of you score above 90. I'm only giving 2 A's. And I got up and walked out of the room, went straight to my catalog and said, what can I major in and not have to take this class? Hence, I'm a zoology major. Sir, thank you very much for the honor on behalf of General Daniels. For allowing me to be here. I'm kind of like a bad penny every time I keep showing up whenever you have something, but thank you for the honor for allowing me to be here. General Brown, thank you so much. AUSA for having me. CSM Dailey, it's a pleasure meeting you. What I've been asked to talk about today is the Army health system in multi-domain operations. I want to start though by taking you back to yesteryear, all right? 3rd Medical Command. I'm going to tell you a little bit of history about the 3rd Medical Command because it also relates to what we're going to see in multi-domain operations. Because whenever we talk about what the next war is going to be, I think it's important to see what the last war we were in that had this type of medical casualty rates. And of course, that's World War II. And that's where the 3rd Medical Command started its existence as the 3rd Surgical Auxiliary Group. This was a group of 16 5-man surgical teams that were embedded in units throughout the United States Army and the European theater. First in the North African and Sicilian theater, and then in, this is our claim to fame. I'm very proud of it. We have the battle streamers to go with it. There are not many, I don't know of any other unit that can say this, but we had part of this division or part of this unit was in the 2nd wave at Omaha Beach, in Utah Beach, and in gliders, both with the 82nd and 101st Airborne Divisions on D-Day. I don't know of any other unit that can say that, and it's a huge piece of history that I like to talk about. Now, why am I saying all that? this was a new concept to put medical care this far forward. As a matter of fact, this unit did not even have an MTO. They literally had to beg, borrow, and steal whatever they needed. So they had to come up with a medical operating concept of how to take care of patients. And it's amazing what they came up with was exactly what we do today. And that is to provide surgical care, return to duty as far forward on the battlefield as possible. So there's a lot, there's not reinventing the wheel, but we've been there before. And I think we've done it. We did it well then. We'll be able to do it well in the future. So what I want to talk about today is what does the Army health system need to accomplish? What are we facing? What do we need to do? What assumptions we can make? What are the 8 key requirements for the Army health system? And basically the central idea of the Army health system in multi-domain operations. And I'm using actually the white paper from the Medical Center of Excellence that was put out in May, and it's based off the Army TRADOC doctrine of the same thing. The United States Army in multi-domain operations. This is the medical operations in MDO. So basically 4 things that we have to be able to accomplish. One is to enable a healthy and fit force and protect it from health hazards. When that fails, we've got to be able to treat what we've come up with. Thirdly, we've got to be able to evacuate patients and enable freedom of maneuver. Because in the war to come, if you stand still, you open yourself up to a lot of bad things. And lastly, the 4th thing we need to do is return to duty as far forward as possible in order to restore combat power. A lot of us already know, we've already talked about what we're facing in the multi-domain operations. Those, you keep hearing about long-range fires that will likely increase the scale, tempo, and distribution of casualties, much like we saw in World War II. We'll have restricted patient evacuation and resupply problems. We already know about the increased lethality of weapons, but when we talk about World War II, we're talking about the same kind of casualty numbers. Remember, we had no body armor back then. The weapons are more lethal, but we do have the armor that we did not have then. But I still think I think you can compare the two in the type of casualty and casualty rates that you're going to get. And lastly, we're going to have compromised communications because of adversarial cyberspace and electronic warfare capabilities. I'm going to tell you a worst case scenario. And the reason I'm going to say worst case, because I don't want to be Debbie Downer either, because I know we got people that are going to help counter the problems that we may have in the multi-domain operation battle. But just think about, you have a combat infantry company, a mechanized infantry company, 20 miles from its parent company, comes under attack from directed weapons, long-range precision fire. Suddenly you have 25 casualties of your 120. Remember, you have 4 combat medics in that company with a senior medic overlooking them, and they're running around. That combat medic has just finished his 16 weeks of protocol-based Army therapy for treating casualties. He jumps into that training with all his might. He's going around. He's already found he's got 5 KIAs. Doesn't have to do anything with that. He uses his buddy aid, the other soldiers with their buddy aid to put tourniquets on the other 3 soldiers. And he still has 13 soldiers left that he's got to take care of. And he's going around triaging it. And within 15 minutes, his aid bag is empty. He's been trying to get resupply from this Class 8 for the last week, but unknown to him, there's been a cyber attack on the web-based program he's been using. And so the battalion never even got his request. So he drops a 9-line medevac request only to find out that the medevacs are being used in another attack. So the company commander has to make a decision. Does he stay here with his people, his wounded, or does he use whatever means available he has to get them out of the way? Because if he stays there with them, he's prone to another attack. And so he utilizes what available means of transportation he has, and he gets his patients, his soldiers, back to the battalion aid station, where now you have a PA, a physician, and 22 medics working on these patients. They've also got casualties coming in from elsewhere. At this point, we have the ability of the soldiers are now being taken care of, and we can medevac them out. Again, this is a worst case scenario, but you can see where we could go with this and have problems in the future, because I know we have people working on the same counter effects so that this doesn't happen to our soldiers. So what do we need to be able to do? And what questions need to be answered? We have to figure out what the hospitalization, actually we figured that out, the hospitalization function capabilities need to be. And we'll talk about that hopefully more in the Q&A. Big question with the hospital, does our electronic footprint make us vulnerable? You light up a hospital and everybody knows it's there. How can we hide that? How can we protect our PII and our PHI of our soldiers? Can we act in a sea-burning environment? And can Army Medicine command and control a joint medical theater? Now, we have several assumptions that go along with this. And the first is that Army Medicine will be part of a joint medical environment. The services are going to retain their Title X control over their medical assets. And disease, non-battle injury, and sea burning is going to be a significant threat in the next battlefield. We're going to have to operate in suboptimal conditions. Here's my other joke of the day is, so when you have a soldier complain that there's not enough porta potties, I may get in trouble for this, sir. When you have a soldier complain that they don't have enough porta potties at their AT, maybe we need to reissue the entrenching tool and have them give a lesson in slit trenching. But the good news is innovation and technology will be able to help support modernization of the Army medical capabilities. DA-PAM 525-3-1, TRADOC has, I'm sorry, this is TRADOC PAM. They have 14 key requirements for operating in the MDO. And Army Medicine has 8 of those. We got to be geographically positioned to support the Army forces in competition and conflict. We need to build partner medical capabilities that are interoperable with ours. We need medical logistics to be a component of precision logistics in order to provide medical supplies from the rear area all the way to the forward battlefield. We're going to have to be able to operate in dense urban terrain, and we will be acting as a joint force. We need to be able to operate effectively in austere environments, as I already said. And lastly, we need to be able to attract, train, retain quality, physically fit, mentally fit people for the medical corps. So what is the central idea of Army Health Service System in support of MDO? Returning soldiers to duty is the most significant contribution that the Army Health System has for the fighting force. To do this, we got to utilize command and control, expeditionary treatment, and multimodal evacuation possibilities designed to rapidly stabilize and clear casualties from the battlefield while maximizing return to duty. But if we can't move them, we got to be able to take care of them where they are. And in this, technology and innovation is going to play an important part. In Facebook the other day, they put a picture of one of our soldiers in training where they had a smartphone with a device connected to it that was an ultrasound. These things are amazing, the things that we'll be able to do. And if we can develop ways to increase and speed our triage and treatment of our soldiers, it's going to be crucial in the battlefield ahead. What I call the holy grail, the synthetic blood. We've been talking about this one for as long as I've been a doctor. We ever get that nut cracked, it's going to be a game changer when it comes to medicine. And I know that General McQueen is going to talk about some of the neat and cool innovations. I don't know if he's going to speak about that one, but the development of 3D printers. I was in a call last week where 3D printers for body parts, knee joints, jaws, things like that, being able to grow human tissue. All of these are unbelievable, innovative things that will come through Army medicine. And conclusion is the Army health system has got to be, or it must have a sustainable design with essential medical capabilities that will unencumber the maneuver battalion commander, and enable the Army and the Joint Force to win its wars. The application of Army medicine and its impact is invaluable because nobody ever won a war by sending all your soldiers to get injured home. They win the war by getting them back to duty as far forward as they can get them. Thank you.
Thank you, Major General Robinson. Let's give him. I know he raised a lot of points. That raises a lot of good questions, and I want you to think about those questions as we welcome our next panelist, Brigadier General Anthony L. McQueen. Brigadier General McQueen is also a native of Texas and a graduate of Sam Houston State University, where he was commissioned as an ROTC Distinguished Military Graduate in 1991. Brigadier General McQueen is a graduate of the Army Medical Department Officer Basic Course and has also completed the Combined Logistics Officer Advanced Course, the Command and General Staff College at Fort Leavenworth, Kansas, and the National War College. He holds a Master's of Science in National Security Strategy and a Master of Arts in Health Services Management. Prior to becoming the Commanding General for Medical Research and Development Command, Brigadier General McQueen most recently served as the Deputy Chief of Staff, G357, United States Army Medical Command, and was detailed to Operation Warp Speed from May of 2020 till May of 2021. Now, what I also noticed about his bio is that he was a member of probably the most prestigious infantry division in all of history, the 4th Infantry Division, and largely because it benefited from great leadership throughout its history. So, sir, thanks for being a steadfast and loyal soldier. And ladies and gentlemen, please help me in welcoming Brigadier General Anthony McQueen.
Well, first off, thank you, SMA Dailey. Appreciate the opening introduction there. And General Dingle, sir, thank you for the invitation to participate in this forum. And also to General Brown, the entire AUSA team, thank you for allowing me to be here today and share some of the greatness that at least I think that MRDC has been doing, is currently doing, and will continue to do. Before I get into my prepared remarks, I did want to say that, hopefully what you'll hear come out of them is very similar to what General Dingle shared with you this morning. As I look back at MRDC now, it's certainly an organization that for decades has been doing greatness for our Army and the Department of Defense. But I would also say that it's probably been the last 2 years of this pandemic that it's been demonstrated and really witnessed by so many of just how great the resources are and the capabilities are and the personnel that make up the team of MRDC. Likewise, as General Dingle stated, we probably have never been nested better with the Army and throughout the Army as we are today. And an example of that is Project Convergence, as we just completed PC 21, and we're already in the deep planning phases of PC 22. And some of that comes with the alignment that we've done with many of our capabilities and organizations like MRDC with Army Futures Command. So I'm convinced it's this way ahead that's going to lead us to be able to accomplish the things that we need to get after the MDO environment. And so hopefully that'll be shared in these prepared comments that I have for you. So certainly the onset of COVID-19 was MRDC's opportunity, and it certainly demonstrated its unique capabilities, and that we've been supporting it from a whole of government response to the pandemic. The Army and the nation response to the pandemic, the Army and the nation, witnessed our organization's relevance to infectious disease research, as well as military medicine as a whole. In addition to utilizing our capabilities, we help detect, prevent, and treat COVID-19. We haven't stopped advancing military medical care in support of the warfighter while that fight has been ongoing. We're able to achieve this because MRDC has a worldwide footprint with teams that's made up of 9 direct reporting units of professionals that work tirelessly in support of our warfighters. We manage and we execute research, development, and acquisition in various focus areas that include military infectious disease research, combat casualty care, military operational medicine, medical simulation and information sciences, and medical, chemical, biological defense research. Military medicine is constantly evolving due to the discoveries and innovations made by our scientists and researchers. At the same time, we have teams focusing on how we get the right products into the medic's aid bag or the new therapeutic to the medical treatment facility. In the development space, we concentrate on getting products and vaccines into clinical trials to test for safety and efficacy so they can be approved and licensed. And on the back end, we seek commercial partners who can take the product to market. There is no other government activity that spans that range. We're the only organization within the DoD solely focused on research and development to address military medical requirements that are unique to the Army. The solutions that we create for these requirements will be crucial to the multi-domain operations. MRDC's unique assets will ensure that our forces are medically ready for all domains of battle: air, land, sea, and space, as well as the abstract domains of cyberspace, including the electromagnetic spectrum, the information environment, and the cognitive dimension of warfare. In previous combat zones, we have been able to administer proper medical treatment that is necessary to service member survival within the golden hour, that precious 60 minutes following the battlefield wound. However, this may not be the viable option in future conflicts. Our adversaries are contesting all domains, and the future battlefield could be one of isolation with the inability to evacuate casualties within that hour or even resupply. Under these delayed evacuation scenarios, if we cannot get the casualty to a higher level of care in a timely manner, we need to think about how we can rapidly move advanced care to the casualty or nearer to the point of injury on the battlefield. We must fill the prolonged field care gap in future scenarios by expanding the window of care so we can turn the golden hour into the golden day. To do this, we're developing innovative technologies that augment, assist, and amplify the capabilities as far forward as possible. Our equipment must become smaller, lighter, and more rugged, but at the same time, it has to be able to prolong life until the casualty can reach the higher level of care. One of our primary areas of focus is blood loss, the #1 cause of preventable death on the battlefield. Determining blood loss and knowing when a patient will go into shock has never been an exact science. It's traditionally been based on provider observation. However, we are working to change that. We are currently looking at technologies that may have the ability to detect signs of shock before it's clinically evident. Ultimately, this type of technology will be used in patient triage and in situations when there is limited provider care. As our future force prepares for conflict in multi-domain operations, it's crucial that military medicine has the right technology to manage large casualty numbers in resource-limited environments. We're investing in advancements that will assist in prolonging life, innovations like medical robotics, autonomous systems, artificial intelligence, and virtual health applications. On the future battlefield, these transformational technologies will facilitate en-route care on autonomous platforms, and they will enable autonomous medical care and machine learning that can support organ function. And as an example, remotely manned vehicles will be crucial to multi-domain operations. Current remotely manned platforms provide troops with timely intelligence, surveillance, and reconnaissance capabilities, and when armed with the right equipment, these already existing capabilities will become life-saving technologies. The growing use of remotely manned systems and robotics on the battlefield provides great opportunities as medical force multipliers. Support from remote or unmanned systems will provide emergency medical resupply, delivery of blood products, and delivery of telehealth or teleconsultation technology to support prolonged field care. While planning for multi-domain operations, our attention is also keenly focused on enhancing human performance. So our warfighters enter the fight at the top of their game, armed with information and data to keep them performing at their peak capacity. To this end, MRDC is leading the Army's overall effort to maximize the potential of our warfighters and teams as they interact in the environment and use and work with technology. Because full operations will place an especially high intellectual, physical, and emotional demand on service members. We are funding programs to address these areas programs for optimal body performance, physical strength, improved nutrition, and sleep. To achieve all this in an era defined by new threats and landscapes, we must develop and acquire bolder medical innovations faster. Our warfighters will need to process a great deal of information more rapidly and more quickly make decisions. As we prepare for the battlefield of the future, we are focused on maintaining and sustaining the Army's primary weapon platform and the greatest asset available to the military, the warfighter. I appreciate your attention this morning, and I look forward to your questions on multi-domain operations.
Thank you, General McQueen, and gentlemen, thank you. And this topic today really needs more time than what we have available. We could talk about medical operations and multi-domain operations for weeks at a time and still have, I'm sure, a lot of unanswered questions that we're going to work through. But the Office of the Surgeon General says he'll have the answers to all those questions by the end of the week. So I think we're going to all be fine. And speaking of questions, gentlemen, the first one of both of you talked about. So it's really for both of you. Multi-domain operations envisions that units will be cut off from external support for up to 7 days when we're talking a near-peer environment. You know, since largely the Vietnam War, we've experienced luxuries like air superiority and the ability to take the evacuation assets directly to the point of injury. And I used to say when I was in Solder City, we landed a helicopter on the street and picked up an injured soldier. I mean, that luxury is something that we earned as a nation, but I don't think it's something we can afford in the future. How are we going to address that in multi-domain operations in the future, gentlemen?
You know, one of the comments that or one of the lines that it says in this pamphlet is innovative patient evacuation means, and that's just another way of saying whatever you got. That's one way to look at it. But also look at it, I think you were talking about using unmanned vehicles for patient evacuation. That way you don't risk a crew coming and going. You can hide it a little bit better. So I think we're going to have to utilize both of those. And I think General McQueen may speak more to that because I don't know where they are in the development of that, but certainly a possibility.
No, sir, I would certainly agree. And there's other armies out there now that are currently using unmanned type platforms to transport casualties. And I don't think we're far away from it. We're certainly looking at it and testing it and experimenting with it. But I also think that probably more important than ever, we've always talked about it, but I think we've got to really focus our efforts at the roll to and below. And what I mean by that, of where that point of injury is. And to me, the most critical is how are we going to manage the blood on the battlefield? It's so critical, as I stated, to save lives. How are we going to sustain and prolong care? Because we are going to have to hold casualties much longer than we have in the past. And how are we going to be able to do that? Whether it's having to have more blood on the battlefield, oxygen on the battlefield, maybe even more capability of holding. And so now we're looking at larger formations potentially of doing that. But I do think also, as I stated, the unmanned platforms, whether it's resupply or evacuation, are going to play critical parts in that as well.
Sir, did you have another comment? Yeah. Excellent. One that both of you have mentioned, but we don't focus on until it becomes a problem, is cyber. Given that people like China and Russia, and even our smaller adversaries out there have increasing capabilities in the cyber domain. What are some of the challenges that we are anticipating from forward edge of the battle all the way back to our hospitals here in the States to prevent infrastructure breakdown through cyber attack?
Well, what I would offer is it's certainly, I think it's been a challenge for the medical community for many, many years. And I think we just recently had some approval from General Murray and Army Futures Command to get after some new initiatives. But cyber's one threat, but quite honestly, we've got to be able to share data and information from the beginning. And so it's a focal point. It will be a focal point going into Project Convergence 22 that'll take place later this year. So I think the first step is, one, getting a standardized system across the medical community that communicates across formations so we can share critical information. But simultaneously, while we're doing that, we've got to take on the cyber piece of it as well.
This one for General Robertson. Sir, we've talked a lot about individual training this morning. It was mentioned by Surgeon General and the Sergeant Major. Could you talk about how the 3rd Medical Command is working on collective training? How are we going to change the way we collectively train for medical in a MDO environment for the future?
Of course, we've spent the better part of the last 15 years attacking entropia in those places. But we have to, and we've started to even this last summer, begin looking at fighting the large-scale combat operations. And on the reserve side, we have a very robust training program with Army Reserve Medical Command through their program. They have four brigades that are dedicated, each one to a different CSTX, and we're shifting focus to the large-scale ground combat operations. What this is going to mean is we need to learn. Well, first we have to go back to the basics. I was just proud of our folks that they got out there and were able to set up a tent last summer, because we haven't done that in so long. And I even asked some of our younger soldiers, when's the last time you put up a tent? And for some of them, it was the first one. So getting back to basics, setting up a hospital. This is the basic part of getting ready for a soldier on how to take care of soldiers on that battlefield.
Thank you, sir. And gentlemen, for both of you, it's a great question. Up until World War I, largely most of our casualties came from non-battle injuries, death through to disease and injury. And we've, again, enjoyed the luxury of great Army medicine that's kept us healthy up until this point. But the recent pandemic has told us, there's threats out there that could affect large-scale operations in an MDO environment. What are we doing to counter this or think about this or prevent this for the future?
So as my opening comments, I think it's critical that with a capability like MRDC, we can't rest on what we've done so far for COVID-19, and we certainly aren't. We've got to continue looking at what are those threats, because quite honestly, while we look at the lethality of weapons out there and the harm that they can do to our soldiers, quite honestly, there's threats like infectious diseases and other types of illnesses that could keep us from even getting to the fight if we're not taking a look at what those are. And so I think it's more critical than ever that from an intelligence standpoint, from a sensor standpoint, that we're collecting that type of information. We know what those threats are out there, and we're utilizing the capabilities that we have to continue to produce whether it's a vaccine or a therapeutic or a prophylaxis. What is it that we need to protect that force that they can even get to the fight and sustain during the fight? So it's an ongoing threat that I think is going to only continue to increase moving forward.
When I was first sending troops out on the UAMTFs, I called a friend of mine, David Marcosi, who used to work in the next door to the White House in the Bush administration on emergency medical management. And I asked him, what were the loss rates of physicians and providers and, healthcare workers in Italy? Because that was the big focus, if you all recall. And he told me that they were in Italy, they were losing 15 to 20% per month. And so I made a speech to my troops going out that you're going into war because, it's not death 15 to 20%, but being taken out of the fight. So you have an attrition rate of 15 to 20%. If you can compare that, we haven't had that kind of loss rates in battle for years. And so I really thought we were sending these people, to possibly into a real type of war, be it not a shooting war. They're going to get a bullet, but they get an infection. So we took great care in making sure that the soldiers had the understanding and the equipment that they needed to protect themselves. And during that first tranche out with UAMTFs, all compos, I know of one soldier in the 3rd Medical Command that got COVID, and fortunately the only symptom they had was loss of smell and taste, but we didn't lose a single soldier to it in the UAMTF movement. So the use and training of the proper equipment, combined with the vaccines that we have, I think are critical in going forward into the next part of that, where disease can be a big part of what we have to get into.
Thank you, gentlemen. General McQueen, this is a great question. How much emphasis is Medical Research and Development Command putting on non-medical and non-invasive approaches to treating conditions, such as things like migraines? And I've seen acupuncture come in the last few years. Can you talk about some of the non-invasive approaches to medicine?
Well, I think most of that you would see, from what I talked about on the human domain and the human performance side of it. That's mostly being executed by our lab at Natick Usarium. And so they are certainly looking at all the different aspects of the body. A lot of it is focused on sensors and wearables and looking at being able to detect things within the body and how the body is performing inside early enough to give indicators of, we've used this for heat casualties. We use it for cold weather casualties. But they're also looking at it from how does it detect where you, based on the different exercises and even the bone density, where you potentially are more likely to have some type of injury or break from a bone fracture. And so I think it may not be the perfect answer, but I think that's probably the closest thing, is looking where we're focused in on that human domain, the human performance side of it.
Thank you, sir. Sir, I think we have time for one final question for both of you. As we prepare for the uncertain environment of multi-domain operations for the future, we know, and Surgeon General mentioned this morning, we can't leave Army of Medicine behind. Those of us that have benefited from the excellent training at the National Training Center have seen that. We plan countless hours for the mission, and the commander puts all the things in there with fires and execution and getting on the objective. And then finally, right before the op order's over, someone says, who's doing casualty vac? Yeah, Sergeant Major will stop by and pick you up on the way. Don't worry. We can't let that happen. We know that. What are each of you doing to make sure that medical stays on the forefront of the planning process in each of your commands? And how are you communicating that to your subordinate commanders?
What we've attempted to do is, one of the good things we've done, and COVID killed it the last 2 years, is to bring our NATO partner nations in to train with us, so that gives us an interoperability with the medical care. We're also looking at trying to get with the NTC and the JRTC to bring the medical units back into there, not just to have a notional army out there somewhere at Fort at Hunter Liggett and at McCoy, but to be out there with them and to get the soldiers to, hey, you really need to practice this part of it. This is going to be just as important as you going and winning the battle, is how you're going to get your troops taken care of. So we're in that process.
So I think from looking internally into the Medical Research and Development Command, the things that I talk to my team about is as we look, first we've got to be able to see ourselves. And what I mean by that is we have to be able to look at each one of the programs that we are working on and how is that program aligned with the Army's modernization priorities. And if it's not, we have to ask ourselves, why are we doing this? And I certainly recognize I'm not the scientist, I'm not the researcher, but as I talk to those folks and talk to my team, I realize there's a space for discovery, and that's why we've been successful for so many decades. But we can no longer do business as we have in the past, and it's got to be aligned with the Army's priorities going forward. And we've got to be able to see how are we performing on those programs? Are we making progress? Are we making the objectives that we've identified? And if not, do we need to kill a program and move that funding to somewhere else in order to get that across the finish line and get it out to the soldiers as quickly as possible? Likewise, from a material standpoint and a fielding standpoint, we're really looking hard at the soldier touch points, getting that feedback from the soldier, because we haven't done our job if we give a piece of kit out to some soldier and they come back and tell us, well, it doesn't work. This is not what I need. It's just going to go on the shelf and becomes a piece of equipment that someone's going to have to account for, but it doesn't meet what the soldier needed. And so we're really trying to increase those touch points. We're trying to do a better job of, when we're doing fieldings, make sure we've got the second phase of the plan, and that's the divesting of equipment and making sure that's not a burden on the units out there. And then the final piece, looking outward, as I talk to senior leaders and both from an Army standpoint and from a DoD, is that we have to continue to build what is the strategy that we want these resources and capabilities to focus on, so that we can go after the right level of funding. We can make sure that we are aligned properly. But it can't just be a project-based, here, work on this and give us what your outcome is. It needs to be aligned with a strategy going forward. Quite honestly, I think we're in a stage where we need to take a look, just like we do any other threat, and how do we align that to O plans, and what is the medical threat out there, and are we truly coming up with those capabilities to get after those going forward?
Well, thank you both, gentlemen. Ladies and gentlemen, please join me in a round of applause for our panel members today.